Okay, good morning, class. I am Dr. Tej Prakash Tawadi, orthopedic surgeon, uh, assistant professor. Today we have a topic of dislocation of shoulder, hip, and knee. It's a long topic, so we have to rush a little bit. Starting with the dislocation of the shoulder and the anatomy and the stabilizers of the joint, dynamic, broadly classified as a dynamic and static stabilizers. Dynamic are the muscles, the long head of the biceps, right over here, and rotator cuff, supraspinatus, infraspinatus, teres minor, and subscapularis. The static stabilizers, ligaments and capsules, superior, middle, and inferior glenohumeral ligaments, labrum, bony restraints, vacuum effect of the joint, synovial fluid adhesion, and scapular inclination. So why shoulder dislocates? It is commonly said as a ball on a tee, golf ball on a tee. So this is a pretty unstable joint. It's mainly due to the shallowness of the glenoid socket. It's a large range of motion, vulnerability during the activity, because it is a highly mobile joint, and different associated conditions like laxity and glenoid dysplasia. In this picture, we can see this is the normal anatomy, and here this is the anterior dislocation, and this is the posterior dislocations. So anterior dislocation is the most common type of the shoulder dislocation. It is mainly due to the abduction and axial rotation. When there is extreme of abduction and axial rotation, and there is a backward thrust in the elbow and proximal distal arm, the elbow gets dislocated easily. And this is the typical attitude of the patient that presents to our emergency, holding the dislocated hand with the normal hand. Clinically, we can see different signs, like there is a flattening of the deltoid and a fullness in the anterior axillary area. This is called Brandt's sign. This is an increase in the anterior axillary fold. The most common test we perform is the Dugas test. That is, one can touch the opposite shoulder and elbow touching the anterior part of the chest. If the patient can touch the opposite shoulder, then we say it the normal, the elbow has, the shoulder has reduced, and it is the test after reduction also we do it to confirm whether the joint is reduced or not. And the other test is a Hamilton ruler test. That means a ruler can toss simultaneously at the same time the lateral margin of the acromion as well as the lateral epicondyle of the distal humerus. In normal shoulder, it cannot touch because of the deltoid muscle, bulkiness of the deltoid muscles. Another test or sign is the Calvé's test. It is the increase in the axillary girth, because the head dislocates anteriorly. There is a fullness and the girth of the axilla is increased. That is Calvé's test. And different nerve can be injured in this, which is the common one is the axillary nerve, and which supplies the cutaneous innervation is in the lateral aspect below the acromion. This is the resiment base area, so also known as resiment base sign. Also, the motor supply is the deltoid. We can also assess the tone of the deltoid also. That way also we can assess whether there is associated nerve injury or not. So anterior dislocation, it has been broadly sub-classified into 4 types. Subcoracoid, the humeral head is below the coracoid process right here, and the subglenoid, when there is a humeral head is below the glenoid of the scapula. Subclavicular, when it more medially, when the humeral head is more medially, it is a subclavicle, and when very severe force, with very severe force, sometimes the humeral head may go inside the chest, that is intrathoracic. And this classification has a clinical implications also. With these subclavicular and intrathoracic dislocations, we have to give more of the axial traction to reduce the shoulder. Unlike in subcoracoid and subglenoid, we can reduce it by just external rotation methods. So how do we diagnose? It's basically clinical diagnosis. It's the typical presentation that patient comes in our emergency with the typical attitude of the limb, and an examination like previously discussed, the typical clinical picture. And further to diagnose, we do some radiological tests like X-ray. This is the anteroposterior view of the shoulder, in which we can see the humeral head is lying outside of the humeral socket. So this is the dislocation of the shoulder. Sometimes the shoulder does not completely dislocate. It dislocates partially, and that is what we call subluxation. Okay, it is the initial phase of the dislocation. This is completely when out of the socket, glenoid socket. So this is a complete dislocation. And in lateral view, there are two lateral views: axillary lateral and scapulary Y view. This is the scapulary Y view, in which the scapula is seen as Y. This is the coracoid process, which lies anteriorly, and this is the acromion process, which lies posteriorly. So this is the normal shoulder. This is the normal X-ray, and here we can see the humeral head is just below the coracoid, lying anterior. So this is the anterior dislocation. In posterior dislocation, we can see humeral head in this area. Okay, there are some special views for the shoulder joint. There are so many associated lesions in the proximal humeral fractures and Hill-Sachs lesion, Bankart lesion. There are associated different lesions, Bony Bankarts. So to assess these associated lesions, there are special views like West Point axillary, Hill-Sachs view, striker nose view. These are not actually not needed in depth in this level. And to assess further, we can do arthrography and CT scan to see associated fracture. In shoulder dislocation, the commonly associated fracture is the greater tuberosity. So if it is fractured or not, we may need to do CT scan. And for the assessment of the glenoid labrum and associated rotator cuff tear, which is common in elderly population, we may have to go for the MRI also. And it has clinical implication in recent days. Doing early MRI, assessing the soft tissue injury in depth, and doing early surgery has been the recent practice these days. So as I said previously, the different bony, capsule, ligaments lesions, Bankart lesion. It is the labral tear, anterior inferior glenoid labrum tear. Like here in this picture, this is the soft tissue labrum tear, and when it is sometimes associated with the bony chip, we call it bony Bankart lesion. Okay, and another lesion we see in long-standing cases, or sometime in acute case also, is the Hill-Sachs lesion. Hill-Sachs lesion. This is the Hill-Sachs lesion. When the humeral head dislocates anteriorly, the posterior superior part of the humeral head is eroded by the glenoid, and in chronic dislocation or sometimes recurrent dislocation, frequent erosion, when there is a rubbing of the dislocated bones, then there is a bony defect, or sometimes when in acute injury also, when there is impaction by the glenoid bone itself, then bony defect is called Hill-Sachs lesions. There are so many other lesions has been described in the literature. Like I said, Bankart, bony Bankart, reverse Bankart. In posterior dislocation, we see reverse Bankart, Perthes type of lesion when there is avulsion in the anterior part, ALPSA, GLAD, and we call another type Hagel, humeral avulsion of the glenoid humeral ligament, and these are of arthroscopic interest in recent days. So coming to the treatment, generally the joint is reduced by closed methods. We need adequate analgesia, and these are reduced in emergency department only, giving some conscious sedation as well as some intra-articular local anesthetics. Different techniques, so many different techniques have been described in the literature, which I have shown in the pictures. This is of ancient, this has become the ancient history now, if Hippocrates methods, in which we give traction and counter traction with the leg, by placing the leg foot in the axilla of the patient, and we usually don't do these days. And simple traction will also reduce, as described by the Hippocrates anciently. And in another method is the Stimson's gravity method, in which we put the patient in the prone position and hang around 4 to 5 kg weight in the wrist, tying in the wrist, and keep it for a while, and the shoulder dislocates by itself. Here I had attached one video, but it's not playing. Another technique is the Coker's maneuver, when we reduce with the shoulder with the axial traction, external rotation. This is the limb is arm is placed in the adducted position in Coker's method, and further adduction and then internal rotation. So traction, external rotation, adduction, we TEAI. Okay, this is the mnemonic. And this method has been found to be associated with more number of fracture as well as neurovascular injury, typically during the adduction and internal rotation phase. When there is inadequate external rotation, the head does not come anterior of the glenoid, and when it comes anterior aspect of the glenoid, and adduction and internal rotation levers the head in the glenoid socket, and during this maneuver sometimes there will be fracture. So recently this external rotation only method is getting more popular, in which the patient can be in supine patient. Supine will be more comfortable for the patient, and occasionally we can do this in sitting position also. This is the external rotation only method, in which we just externally rotate the limb in abduction. In this position, unlike in Coker's, this is in adducted position. Here we external rotate in abduction, and when we see and feel the head of the humerus coming anterior aspect of the glenoid socket, then we just lift and adduct, internal rotate. That will reduce. So, and usually that also not required in external rotation only method. Only external rotation only when we go beyond 90, 100, 110 degree of external rotation, that reduces itself. Occasionally when it's difficult to reduce, this is what is called as Mills maneuver, when we when we push with the thumb or with the help of another assistant, we push the glenoid head in the socket from the axilla anteriorly, and pushing the humeral head. This maneuver is called Mills maneuver. Other technique is when the resistant cases, when other techniques fail, then Fierce technique has been described, in which we give axial traction, and this patient with upward and downward around 5 centimeter up and down in neutral position and external rotated position, when and slowly abduction in 90 degree of abduction, external rotation, we do external rotation, and beyond that, when we go up to 120 degree of abduction, it reduces itself. Another easy method is scapular mobilization method. The difficulty in other methods is mainly due to the when there is inadequate analgesia, patient tends to move the shoulder itself along with the limb. So we are controlling only the limb, and the patient he himself or herself moves the scapula. That way, it is difficult to reduce. So we have to, in other methods, in all these methods, we have to stabilize the scapula with the help of one assistant. And in this scapular mobilization technique, keeping the patient in prone and hanging the limb down, just holding the inferior pole of the patella, lifting medially, and the lateral end distally. This will reduce the shoulder. So coming to the treatment, all required is only arm sling for a few days for elderly patient beyond 30 years, because these patients are prone to stiffness. So for more than 30 years, we keep arm sling just for a week and give analgesics on as required basis for a few days, and then if when pain subsides, we no more give the analgesics. However, for the young generation, younger people less than 30 years, because of the large tears in the labrum and other associated soft tissue injuries, we tend to immobilize for around 2 to 3 weeks, so that the lesions heal up itself and the chance of dislocation is less. It's also because in less than 30 years, the chance of recurrent dislocation is very high. So to reduce that recurrent dislocation, we tend to let the soft tissue heal adequately. So we keep for more duration in younger people less than 30 years. When there is associated Bankart lesions, it is generally described in the literature as axial rotation splint. So we have to keep the patient in axial rotation. Splints are required, but generally we keep just to give the shoulder immobilizer, and that is enough. So what are the complications? It has been subdivided into early and late. As I previously said, rotator cuff tears in elderly, especially in elderly. Knob injury is said axillary knob. There is regiment badge sign. Vascular injury, axillary artery, especially in the elderly when the artery is sclerosed, arterial walls are sclerosed, and when there is a large displacement of the humeral head, there can be vascular injury. Fracture associated fracture greater tuberosity. If it is more than 5 millimeter of displacement, and that is a criteria for that needs reduction, and it is one of the criteria for open reduction also, when we cannot reduce to up to less than 5 millimeter of the displacement. When we cannot reduce the displacement, we may need open reduction also, and we usually fix with the K wires and personal wire and sometimes screws. And late complication, as said, in any dislocation we have stiffness and like the shoulder stiffness, and usually sometimes the patient from the remote places, they come with unreduced dislocation. So in the literature, it has been described as like up to 6 weeks. Up to 6 weeks old, it is worth attempting for close reduction. But in this unreduced dislocation, we have to make sure of adequate analgesia and anesthesia, and we have to reduce only in operation theater, because the bone is already weak due to 6 weeks of late up to immobilization of that period. So there might be iatrogenic fracture of the proximal humerus. And another complication is a recurrent dislocation. When we have more than 2 in a year, or when some literature say more than 3, then that is a recurrent dislocation. It ranges from 17 to 96%. It depends upon the age of the patient. So after when there is recurrent dislocation, we have to do apprehension test. Apprehension test, we external rotate and abduction, and just give upward thrust of the proximal humerus. When patient feels sensation of dislocation, of giving away of the shoulder joint, and as if the joint is dislocating, and that is the apprehension test, and that is suggestive of the unstable shoulder that needs further address, so that these patients are prone to recurrent dislocations. Now this was all about the anter-shoulder dislocation, which was more common. Now coming to the posterior shoulder dislocation, it is only about 2%. It is very rare, and it is mainly due to the internal rotation and adduction. When the we know that internal rotator and adductors are more bulkier, so in seizures, and when the patient fall in outstretched hand in flexion and adduction in this position, and this, in this typical position, there might be the posterior dislocation, and it is usually frequently missed even by the orthopedic surgeons, because the typical X-ray picture is not that typical. It is the attitude of the limb we have to assess, and the limb is locked in internal rotation, and front of the shoulder looks flat. We can see in this picture. This is a typical picture, and we sometimes in obese patient we do not see the typical picture like this. There is a dimple. See, this is the acromion, and below this there is a dimple, which usually is full, and this prominence of the coracoid process, just in this area we can feel coracoid by ourselves normally also, and this pad, in this dislocation, posterior dislocation, it is more prominent. And with the X-ray, the same AP and axillary or scapulary Y view, what we say, it is a light bulb sign. This picture shows, and this is the normal X-ray we have here with this, and this is the posterior dislocated shoulder. This looks like the head is in relation with the glenoid, but this is the posterior dislocated shoulder. This position of the humeral head is due to the extreme of the internal rotation. The limb is held in internal rotation. Occasionally we see this similar type of X-ray when we do the X-ray in normal people also. When we do the X-ray in keeping the limb in the internal rotated position, sometimes it comes, patient comes with the normal shoulder having this sort of picture with the light bulb sign. It is mainly due to the posterior dislocation. And another is the empty glenoid sign. There is typical collinear, with the glenoid and the humeral head should be collinear, and this, like this in this picture, which is not there in this posteriorly dislocated one. So treatment: traction in adduction and axial rotation. Traction in adduction and axial rotation, and gently head is pushed forward. Sorry, I forgot to say in this lateral view. This is the scapulary Y lateral view, in which the humeral head is lying posterior of the glenoid. Right here is the glenoid, and this is the acromion. This lies posteriorly. This is the posterior dislocation. So treatment, traction in adduction, axial rotation. Head can be pushed gently forward, and it reduces very easily. It is usually stable, so only sling is enough for elderly patient a few days, and as the pain subsides, we have to mobilize as early as possible to avoid the stiffness, shoulder stiffness. In unstable, aeroplane spleen to heal the posterior capsule in shortest position. In this position, we can place the patient spleen. We can give the spleen in this abduction, action, rotation position. This the aeroplane spleen, so that the posterior capsule gets healed in the shortest position, so that the capsular ring is filled up, healed, and avoid the recurrent dislocation, which is very rare. Inferior dislocation, which is also known as Luxatio Erecta, and this is the typical clinical picture when patient comes with hyperabduction and holding with opposite hand. This is the typical presentation of the patient, and clinically we can say this is the shoulder is inferiorly displaced. Sorry, and the force is hyperabduction, severe hyperabduction force. And the humeral head is levered on the acromion down below the glenoid. Treatment: for the reduction, we need to give axial traction, gentle upward push, whereas stabilization of the shoulder by pressing from the proximal end. This way we can easily reduce. If it is not reduced, we can gently push the head anteriorly and do the maneuver of the anterior dislocation. And you as a medical officer, when you finish your MBBS and while posting in the emergency, you all should know how to reduce the anterior shoulder dislocation. I suggest you to go in the YouTube. There are plenty of videos. You can see the videos and learn how to reduce the shoulder dislocation. It is a common problem, orthopedic problem you see in the emergency. Coming to the recurrent habitual dislocation, these are the people who have hyperlaxity of the joints, and we assess the hyperlaxity by Beighten score, Beighten hyperlaxity score. Dorsiflexion of the little finger beyond 90 degree, and touching the thumb, touching the forearm with the thumb. I cannot do. See? And hyper dorsiflexion of the wrist beyond 90. This is the hyperextension at the elbow. Hyperextension, normally it is a straight, elbow is straight, and hyperextension of more than 10 degree. Up to 10 degree is normal. Hyperextension of more than 10 degree in elbow and knee. Coming as these all four parameters are bilateral: hand, thumb, little finger, thumb, elbow, knee. Altogether 8 score. And if the patient can touch the floor with the palm of the hand and knee extended, this 1 score for this. So out of this 9, if patient has more than 4, this is more than 4, then this is a hyperlaxity. There are associated lesion, Bankart lesion, Hill-Sachs lesion. So the treatment for habitual is arthroscopic surgery, different and sometimes open surgery. Bankart repair, modified Bankart, near capsular shift, lateral Z procedure. Okay. So coming to the knee dislocation, I think I have to rush. These are the traumatic injuries characterized by high rate of vascular injuries, and in 0.02% of the orthopedic injuries, these 50% of the patient come with self-reduced. So in literature also this is underreported. This because of this patient usually doesn't present with this typical deformity in this picture. The mechanism is dashboard injury and the sports injury. Stabilizers of the knee, bony, and the static and dynamic bone, capsules, collateral ligaments, meniscus, and dynamic, all the muscles around the knee. So clinically, we can see if the patient is presents with typical deformity, we can easily confirm with the clinically also. To dislocate at least 2 of the 4 ligaments, anterocruciate ligament, posterior cruciate ligament, medial and lateral collateral ligament. These are the main stabilizers of the knee. So at least 2 of the ligaments should be injured for the ligament, for the knee to dislocate. So as 50% present with self-reduce, so we should have high index of suspicion. And there may not be always the obvious deformity, but we should be suspicious with the large swelling. If there is rupture of the capsule, there might be severe bruising, like in this picture. When we suspect vascular injury, we have to measure ankle brachial pressure index, ABPI, the ankle and the ratio of ankle and the brachial pressure. If it is less than 90, usually the ankle, the calf, when we measure pressure at the calf, the blood pressure is higher than the arm. If it is less than 0.9, we have to monitor for the vascular injury, and we need to go for the angiography. And regular, what we do in clinical is half-hourly serial monitoring of the pulse of the dorsalis pedis and the posterior vessels. Immediate exploration if pulse absent, even after reduction. After reduction also we have to, and there is 86% amputation if the ischemia time is more than 8 hours. The commonly associated injuries are vascular injury, which can be intimal tear as well as full thickness rupture. Nerve injury, usually, sorry, the common perineal nerve, which is seen in 25%. Tibial nerve injury, in 60% of cases, we see fractures. Soft tissue injuries, patellar tendon rupture, periarticular avulsion, displaced meniscus. It has been classified initially by the Schenck, type 1 single cruciate plus collateral ligament injury. In type 2, both the cruciates are injured. In type 3, 3M and L with the MCL and the lateral collateral ligament. Type 4 is all the 4 ligaments are torn. And V, fracture dislocation, associated fracture. C, arterial injury and nerve injury. Another classification is given by the Kennedy, that is basically on the position of the distal tibia in relation to the proximal femur, anteroposterior, medial, lateral, and rotatory, anteromedial, anterolateral, posterior medial, posterolateral. Posterolateral is most common and very dangerous also. It is difficult to reduce. Imagine X-ray, knee AP and lateral. We have to assess the asymmetry of the joint line, avulsion fracture, Sigonstein, like in this here, avulsion fracture of the proximal tibia and the lateral aspect. This is typically suggestive of the anteroposterior ligament injury. Osteochondral defects, CT scan, which we usually do after reduction, because it's simple, small fractures we miss in the X-rays, and we have to assess by the CT scan, like tibial eminence fracture, in a tibial tubercle, tibial plateau fractures. MRI to assess the soft tissue and ligaments, meniscus injury. And we do MRI after reduction, but before fixation, as we usually place stainless steel implants when there is associated fracture. We cannot do MRI with the implants. Hallmark of the posterolateral is irreducibility. Medial femoral condyle buttonholes in the middle capsule, medial collateral ligament invaginates into the joint. There is medial furrow. Then this type may needs open reduction. Treatment: close reduction. We have to avoid hyperextension. In anterior type, traction, intertranslation of the femur. In posterior type, traction and extension, and slow extension and intertranslation of the tibia. And we have to keep the patient knee in 20 to 30 degree of flexion, so that the collateral ligaments heal in their normal anatomic position. We go for check X-ray and vascular consultation if required. Open reduction only if vascular injury, open fracture dislocation, irreducible dislocation, and there is compartment syndrome. And then we keep them in the external fixator. Treatment: conservative versus surgical. Recent evidence shows is towards the surgery for the functional, good functional outcome, return to walk and early return to sports. Surgery usually done in 2 to 3 weeks. Ligament repair and repair, augmentation, reconstruction. These are done after ACL, PCL. These are done these days arthroscopically. And the posterior and posterolateral corner, these are more superficial, so we can go for open repair. Complication: vascular injury in 5 to 15%, common perineal nerve injury in 25% of the cases, late joint instability and stiffness. Coming to the hip, it is a pretty stable joint because of the socket, acetabular socket, and the femoral head, capsule, labrum, ligamentum teres, iliofemoral, pivofemoral, and the ischiofemoral ligament. Like in this picture, you can see. Broadly, it has been classified into the posterior, anterior, and the central. The posterior, unlike shoulder, the posterior is common in hip. The typical mechanism is the dashboard injury. When the knee joint, the distal femur is pressed by the dashboard, then hip dislocates posteriorly. In the road traffic accident, fall injuries also. The typical attitude of the limb is flexed, adducted, and internally rotated. And other associated injuries will be while the head is coming out, it injures fractures the acetabular. There might be femoral head fracture, sciatic nerve injury, and ipsilateral knee injury, late complication, osteonecrosis. Thompson and Ifton has classified, subclassified pure posterior associated chip fracture when the acetabular is comminuted, and acetabular floor in type 4, in type 5, there is with fracture of the femoral head. Anterior dislocation, 10 to 15% of the cases, external rotation and abduction force. Actually, the limb is axial rotated and abducted. This is the typical picture. And Ifton has classified anterior dislocation also in superior and inferior or pubic and obturator type. Since this is a high velocity injury, ATLS protocol is followed, ABCDE, and 95% have associated other injuries, so we have to examine head to toe, and classical attitude of the limb, careful neurovascular evaluation, knee for associated injury. X-ray, this is the typical X-ray. The main thing we have to follow is the Schenck's line, which is continuous with the inferior cortex of the neck, and which is continuous with the inferior border of the medial neck and inferior border of the superior pubic rami. CT scan and MRI. Treatment, close reduction. There are different, this is usually done in operation theater, as it needs adequate relaxation as well as analgesia. Different methods are there. LEs, when there is axial traction and flexion, rotatory movement, and Bigelow traction, adduction, internal rotation. East Baltimore lifts, like in this picture. Stimsons, these are all described, and this LEs is the typical method we follow, and I suggest you to go to the YouTube to see the technique. Enter dislocation, reverse Bigelow, open reduction if it is irreducible, radiographic inconsistent fragment, delayed presentation, non-concentric reduction. Complication, post-traumatic arthritis, femoral head osteonecrosis, sciatic nerve injury in 8 to 20% incidence, recurrent dislocations. Thank you so much. If you have any